Yes, hello everyone from Cat Island in the Low Country. I'd like to thank Dr. Walker for the opportunity to present in this digital education series. I'd also like to thank the NCBH team for making it all happen. The title of this discussion is The Prevalence and Epidemiology Burden of Peripheral Artery and Venous Disease in Women. So disclosures, none that are relevant to this discussion. First, we're going to talk about women and PAD. There's a myth that PAD is a male disease, and that was based on the old definition of PAD as intermittent claudication. However, women rarely have intermittent claudication. In fact, 90% don't have the symptoms of IC. In contrast, numerous US studies have found a higher incidence and prevalence in females, particularly in the older age groups, in African Americans, and or those with diabetes or CKD. There's also evidence of higher CLI incidence and prevalence in females from US and other studies. Symptoms, severity, and the impact of risk factors, however, vary with gender. So how many women in the US have PAD? In 2020, we estimate 11.4 million women of the 21.3 million with PAD. This is based on the diabetes method, and the prevalence in those 45 to 64 is the same for men and women by glucose status, and it's the same in those with normal glucose in those age 65 and older. The key difference is that women with diabetes and impaired fasting glucose have higher PAD prevalence in the 65 and older age group. So if we compare that 11.4 million with a couple of other estimates, 11.1 based on Nealer's percent prevalence in the population, and 11.8 million based on Mansour's prevalence in the population. So someplace in the mid 11 million seems like a good number. Female prevalence of selected chronic diseases. We see that 11.4 million with PAD is only exceeded by 16.2 million with diabetes. Note that PAD is 3 times more common than breast cancer at 3.8 million. Risk factors in women, generally the similar as men, include age, smoking, diabetes, hypertension, and dyslipidemia. However, smoking has a greater impact on women. If the person smokes less than 15 cigarettes a day, the risk factor is 12 times higher. However, more than 15 cigarettes a day, the risk factor is 21 times higher. Now, CKD is a particularly important risk factor for women in all racial and ethnic groups. Even moderate and severe renal insufficiency increases the risk of PAD by 1.6 times and 3.2 times. In addition, multiple risk factors have a stronger impact on women and increase the risk more. Some patients with 3 or more risk factors, the risk of PAD increased almost 19 times in females versus 6 times for males. If you look at the annual economic burden of PAD in women, it's between 147 and 277 billion. Turning to women in critical limb ischemia, we estimate about 50% of the CLI population is female, so 1.9 million. More women than men present initially with CLI, and this reflects a higher prevalence of asymptomatic disease, underdiagnosis, and lower rates of intervention at earlier stages. There's a different lesion distribution and morphology, a higher risk for CTOs, multi-level disease, and fem-pop disease, and unfortunately, female gender significantly increases the odds of above-the-knee amputation. Women in asymptomatic disease. Approximately 9.1 million women have asymptomatic disease, and asymptomatic disease is 1.3 times to 1.6 times more frequent in women than men. Now, asymptomatic doesn't mean they don't have any symptoms. It means they don't have the classic symptoms of intermittent claudication or critical limb ischemia, but they do have mobility loss, reduced leg strength, and other symptoms. And unfortunately, women with asymptomatic PAD have a higher risk for non-fatal MI. That's 2.4 times the risk versus 1.4 times the risk in men. So conclusions on PAD. It's a myth that PAD is a male disease. 11.4 million US women have PAD. 3 times more US women have PAD than breast cancer. The economic burden of PAD in women is 147 to 277 billion. Critical limb ischemia prevalence is 1.9 million women. And female gender significantly increases the odds of above-the-knee amputation. So turning now to venous disease. Female sex is a risk factor for chronic venous disease. Female sex and multiple pregnancies. We look at the female prevalence of selected chronic diseases. We look at varicose veins at 38 million women versus, that's twice as many as with diabetes, 16 million, and 10 times as many as with breast cancer. Now, varicose veins, again, we said 38 million. Symptoms: heaviness, tiredness, tenderness, itching, aching, pain, and swelling. But this may be an asymptomatic condition. And varicose veins are not just a cosmetic problem, but a manifestation of chronic venous insufficiency, CYP3 to 6. Varicose veins do progress to more severe disease, including ulcers, at a 2 to 4% annual rate in low-risk patients, at a 5 to 8% rate in high-risk patients. Looking at chronic venous insufficiency, CVI. Overall, we estimate 30 to 50 million with CVI in the US. Prevalence is similar in males and females, so 15 to 25 million women with CVI, making it 4 times to 7 times more prevalent than breast cancer. Venous ulcers. The US annual incidence of venous ulcers is 1 to 2 million, so females 650,000 to 1.3 million venous ulcers. And incidence increases with age over 65, so the venous ulcer patient is more likely to be an elderly woman. The US cost of venous ulcers, treatment costs for venous ulcers in females between $11 and $30 billion. Venous ulcers reduce productivity and increase costs. Venous ulcer patients in one study lost 40% more work days, or 14 days a year on average, at a cost of almost $2,700, and approximately 70% of these were female. VTE is a reproductive health risk. Pregnancy increases the risk of VTE by approximately 5 times. DVT prevalence in pregnancy is 8%. PE prevalence is less than 5%, but PE is the leading cause of maternal death in the US. Combined hormonal contraception increases the risk by 2 times, and the newer agents unfortunately have a higher risk than the older ones. Infertility treatment is also a risk factor, and hormone replacement therapy increases the risk by 2 to 4 times. So conclusions on the venous. Female sex is a risk factor for chronic venous disease. 38 million women in the US have varicose veins, 10 times more than breast cancer. Varicose veins are dismissed as a cosmetic problem, but they're actually a progressive severe disease, progressing at a 2 to 8% annual rate to more severe disease, including ulcers. The prevalence of CVI is 15 to 25 million women, or 4 times to 7 times that of breast cancer. The economic cost of venous ulcers in women is 11 to 30 billion. VTE is a reproductive health risk. Pregnancy, oral contraceptives, HRT, etc. increase the risk of VTE. Thank you.